Good afternoon, everyone. This shouldn't interrupt your lunch. It shouldn't interrupt the atmosphere. We'd like this to feel like a comfortable discussion in your dining room. We're not, for example, going to be giving you 4 speeches with slides. Instead, what we're going to do is have a conversation. And we're going to start by having a conversation with each other, but then we're going to move to having a conversation with you. And the topic is about models of collaboration. This conference and the work at Practicable Playbook is all about understanding the importance of building the partnerships between public health, the healthcare sector, and other key sectors. But I think we all would agree building those partnerships is not easy. It takes real work. It takes understanding the issues, building relationships, testing things out, failing, learning lessons, trying again. And so what we're going to focus on now is giving you some real life experiences or best practices from the perspective of people who are representing different sectors. We're very fortunate because we have an extraordinary group of individuals here that will be sharing their experiences. I'm going to start just by giving you the experience for a minute about CDC. We've decided that a key role for us is to provide some concrete and specific tools that can help people as they're practically going about building these collaborations. You've heard, I think, already about the notions of the 3 buckets of prevention, which is a guiding framework for us. We've developed a campaign that focuses on clinical intervention, 618, and we're going to be soon unveiling an approach that offers another tool that looks at population health, population-wide interventions that are also evidence-based for use in these practical approaches. You'll be able to get that information from the Practical Playbook. But the 3 members that are sitting next to me have very specific information to share representing their sectors. And I, in the interest of time, and since this is a conversation and not a speech, I'm going to ask each of them to spend maybe 3 minutes introducing themselves, so I don't have to do that, telling you who they are, what they do, what their organization does, and telling you for a minute or two how they're involved in the issue of building collaboration between public health and clinical care. And so I'll start with the person on my left.
Okay. Good afternoon, and thank you. I'm Esther Dyson, and I founded The Way to Wellville in May of 2013. And I come from Silicon Valley, the tech data geek world, and a lot of my friends said, oh, just give them all a Fitbit and you'll be done. But I suspected that wasn't really the case. So the first thing I did was to find a CEO, because I've seen lots of well-meaning efforts just fall apart because the person who ran them didn't know much about what they were doing or maybe what they were disrupting. Our CEO is Rick Brush, who did community health at Cigna, among other things. Very briefly, we put out a call for applications, and you had to be under 100,000 people. You had to be geographically remote so that whatever happened in the community really affected everybody in the community, and they weren't going out for lunch or coming into work and then disappearing. And you had to have an existing coalition of different entities that were already focused on the cultivation of health. To our great surprise, we got 42 communities, and in the summer of 2014, we visited 10 of them, which was a huge education all by itself. We picked 5. One has since dropped out, but the remaining ones are Spartanburg, South Carolina, Clatsop County, Oregon, Muskegon, Michigan, and Lake County, California. In terms of collaboration, the one thing I want to say, and then we can keep going, our collaboration isn't just between public health and the health system. It also includes the churches, the schools, very important, they feed the kids. But perhaps most interestingly, we're working with the private sector. Omada Health, I'm an investor in that company, full disclosure. I invested in them before Way to Wellville. I've stopped investing because I don't want to put an asterisk after everything. But I think there's less of a need for alignment of interest. You don't all need to want the same thing out of a collaboration, but you need to want things that are complementary. I think it's good for companies to want to make money because they make money by being successful if you define things right. If you focus on the outcome and you pay companies for the outcome, they want you to succeed. Meanwhile, the community's interest is the community themselves. And to be candid, Way to Wellville's interest is in showing what it looks like when you do this kind of collaboration and you have multiple interventions reinforcing one another instead of one separately that's really great to study if you're a scientist but doesn't have a lot of impact. So our interest is for people to say, wow, look at what happened in Wellville. We should change policy so that, for example, the schools work together with the health system. They subsidize vegetables, they couldn't tax sugar, but maybe we should. There are lots of things we can't do, but the stuff we can do is collective action. Maybe at some point policy can do as legislation.
Great, and we will follow up on some of the points I think you've begun to talk about. Lamar.
Thank you, John. Good afternoon, everyone. I am Lamar Hasbrouck. I'm the Executive Director of NACHO, National Association for County and City Health Officials. And by way of introduction, I'm going to give two self-disclosures. The first one is that I am bilingual. So I speak both public health and I speak primary care. That's important to know and to recognize because not everyone is. And so as we tackle this practical playbook and we're looking at the public health speak, which includes things like surveillance, monitoring, epidemiology, sanitation codes, regulations, child and CHIPS, unfunded mandates, we have to understand that the other side of the aisle is talking in terms of patient panels, clinical guidelines, compliance, loss to follow-up, standards of practice. So we just have to recognize that everyone is not bilingual, and so that's going to present a challenge in trying to bridge the gap between the two, and obviously the practical playbook should be one of those bridges, and that's what we're here for. The second disclosure that I'll make is that I am a former collegiate athlete, and I've been socialized in sports for my entire young adulthood. And so when you tell me you got a playbook, the first thing I'm going to recognize is that in order to execute any playbook, you got to have a couple of things. Number one, you got to have a coach. And that coach has to be authorized to make the play, to make the call. Number two, you got to have some players. Players got to be practiced and know their position on the team. And then thirdly, you need a quarterback, right? You need somebody on the field that's coordinating the moving parts, the moving pieces, or the players. So just imagine, if you will, that you're showing up for a contest. In this case, the thing in front of us is to improve population health. And you have no coach, you have no players, and you have no quarterback. I think that you would probably concede that it's time to forfeit that particular contest. So those are two pieces of disclosure, and I want you to know that because as I talk and give you my opinions, they're going to be colored by those two things. So what is NACHO? For those of you who don't know, and I believe most of you do, we represent 2,800 local health officers, and by extension, those health departments, and by extension, those 160,000 frontline public health workforce. As the Association for Local Governmental Public Health, we then serve to be a leader, to be a partner, to be a catalyst, and to be the voice of local public health. In short, we help them do more, better. We have about 125 staff here in DC, and when I say we, I'm really talking about they, because we are they, because everything that we do on behalf of our members is really powered by our members. So if it's the agenda, if it's the policy that percolates out of the 40 advisory groups, if it's whatever else that we're putting in front of ourselves, it's really powered by the members. And I can tell you that we collectively, the members and the staff, understand that the nexus between public health and primary care is really a sweet spot and a place we really need to go. In fact, I have said that we're probably looking at about a 3-year horizon before we need to get our act together, either get on the train or get left behind in terms of governmental public health. So this is a very, very keen area for us, and I look forward to the robust discussion going forward. Thank you.
Great. Thank you very much. And Julie.
Thanks, John. My name is Julie Wood, and I'm a family physician, and I'm here representing the American Academy of Family Physicians, which is headquartered in Kansas City, or Leawood, Kansas, to be more precise. And we have about 125,000 members, the frontline family physicians in the country, and speaking the primary care and some of the public health, we're working on that. This has been a very important area for us over the last about 3 years, where we've really stepped up our game in how to best work with our public health colleagues, and particularly how to support our members that are already in the field. As you can imagine, with family physicians across the United States, they're often in multiple different practice settings, small, large, rural, urban, inner city, and trying to assist and determine what is the best way to intervene or to provide support is both fun and a challenge. And we're continuing to work on that. We put out a position paper over the last about year and a half, and that important piece of that was a call to action to our members to really get on board with just what you were talking about, Lamar, seeing that this is very important for the nation's health and also for the way we practice, that we both have some important pieces of infrastructure, but until they come together and work as a whole, we're not going to affect that and move the needle. So that's what we're working on. In our call to action, we have asked for our members to think about what their role is at the immediate physician level, individually, at their practice level, how they integrate with communities, with public health, with hospital systems, and so forth. We've asked them to look at education, and that comes within our academy as well. So how do we impact how we're educating our primary care physicians from the very beginning? But the other piece of that is also to coordinate that with our already practicing physicians, that maybe they haven't had the experience of discussing population health. We're often trained in medical school to think about population health as a panel, not in the geographic manner. An important piece of what we're trying to work on with our academy is looking at both population and community health. And often now we're finding that we have to say that to get that in, because we've gotten so used, population health is kind of swelled up, people kind of are on board with that, but they're still thinking, originally we had the one-on-one relationship with the patient, which is still very important. But we also now have this panel, and now we have a population, and now we have a community. And how do we bring all that together, I think, is really important. And that's what we're working on as a primary mode of support within the AAFP. So I think we'll probably get into that a little bit more.
I think we will.
Okay.
Well, thank you. Thanks to the three of you. By the way, I was tempted to ask Lamar to stand at the podium and do simultaneous translation for the rest of the conference if people were using acronyms from one sector or the other. So, Lamar, would you be open to doing that?
I can do that signing if we need to.
Thank you very much. Well, maybe what I'll do is, explore a little bit. You've talked, each of you comes from a somewhat different sector, a somewhat different approach to this, from the perspective of the physicians, from the perspectives of the local public health authority, from the perspective of the private sector, but linked to multiple sectors and communities. Let's for the sake of this exercise, this discussion, create a scenario where we've got a community that's ripe for this kind of collaboration and partnership. Tell us just, maybe I'd ask each of you just for a minute to say, let's say there's a meeting that's coming up, or to begin to discuss how to develop an approach in that community that would be a collaborative approach. What do you see your sector's contribution or to that kind of discussion? And maybe, Julie, I'll start with you.
I think I'm going to tee off of Lamar's comments on being bilingual. I think that's one of the, that's a great way to put it. And I hadn't thought of it just like that, but we're still not speaking the same language. So whatever we can bring from the primary care physician community, along with some of us that are bilingual, and then how do we integrate better with public health? The playbook has a great section on vocabulary and language, but I think that's an area where we can all continue to work together. I think it's the old challenge and opportunity dichotomy because it's still a big challenge, and I think it's a barrier, but I think it's a great opportunity, and we really are not speaking the same language in many situations.
So you would bring to the table a bilingual clinician who was prepared to do what?
I think it could be helpful if we could work on it both ways. So if we could have a physician that's present that already integrates well with public health and can speak that language and discuss, hey, this is really, we're in this for the same reasons, and we have the same goals, and how can we bring that together and really achieve those? Because I don't think in many of the situations I've encountered, in the trenches, boots on the ground, if you start talking one-on-one or in small groups, that comes across, but some of the initial listening or learnings don't get that elicited and pulled forth in a practical way, in a sustainable way. So I think bringing both the physician in, but also from the public health community, somebody who speaks physician and care, and all those things like you're talking about. We're in a morass of bureaucratic change and payment reform and all of that, and that will be another important point, I think, to bring together, and how we can work on that together and help each other, both ideally to take care of the patient and our communities, but also how do we get paid? I'm just throwing out the elephant in the room.
And if I was in a community and I was thinking, who are the physicians I should be inviting? Would I approach your organization? How would you think I would find those?
For family physicians, I think we have state and local chapters, and I think particularly the state chapters, you can always go through the AFP, and if you have a group or your area that wants to be plugged in, we can certainly put you in touch. And we have a variety of activities going on, from those that are very novice and early in involvement and integration, some that are quite advanced and doing well. So we would be glad to help with that.
Lamar, I imagine public health would play a role in convening that meeting, perhaps, or be actively involved in thinking about
Thank
it.
you for teeing me up there, John.
Yep, okay.
We are conveners. One of the things that we would do, Nature National Association, right? We're helping our members who are on the ground doing the work. So really, one of our key roles is really to give them the coaching that they need, to give them the tools that they need, to help them make that value proposition, the case for partnership at the local level. So if they were to walk into that room, then they could assert themselves and say, well, we're the keepers of the data. That's a huge currency in this, in trying to understand the community, trying to understand the priorities. We're familiar with doing the community health assessments and the priorities and things like that. So it really is about having that local health officer, where it makes sense, and it may not always make sense, step up and be that quarterback, play that quarterback role within this community. There's a lot of things that, another term for quarterback could be a chief community health strategist, right? And so that's the person that really is trying to connect all the dots, and there's a number of advantages for them to do that. One is that they have the legal response and authority for really population health or community health. Two is they have the macro view. Three is they have this currency of data. They're the collectors or the keepers of the data. And then, as you alluded to, they're the great conveners. So they're regularly and routinely convening groups of stakeholders, teachers, parents, healthcare delivery folks and other associations, hospital staff and the like, to come together to look at this and strategize. So, our role is really to help empower that local health official to really assert him or herself in that role where it makes sense.
Great, thanks. Esther, you've worked now with these 4 communities, and
right.
What's your sense of what you'd bring to the table?
Yeah, I'll sort of mix my metaphors a bit. We're kind of like personal trainers in that we were invited in, but it's still their body. It's their community. They're responsible. They do the contracts. They're going to be dealing with the impact or lack of impact. And so what's great about us is there's 5 of us, 4 of us. Maria Stark here is in charge of Clatsop County. We each of us have one of the communities. We don't want their jobs. So we're kind of external to the politics. Politics always exists. And at least in our world, it's really important to understand it's not just the formal role somebody has, but their individual capacity. We've seen good public health officials and ones that weren't quite as effective. We've seen different entities like the schools and the health system work together very well. I sat next to a guy in a uniform in Spartanburg, and I asked him who he was, and he said, well, ma'am, I'm Neil Urch. I'm the deputy sheriff that runs the local jail. We discovered we got the same customers in mental health service, and we're now working together. And that was great. It depends, especially in smaller communities. The school superintendent may have been taught in kindergarten by the lady who sits on the Mary Black Foundation board. All those things help deal with the politics. They don't necessarily deal with the financial, and you still need incentives to make things happen. Anyway, so our role is to come in and kind of have everybody's back and at the same time be an external prod to getting people to work together, informing them about what Robert Wood Johnson Foundation may be interested in funding next year. So we're kind of trying to be the catalyst for these things to happen. We're not, a nice white lady from New York is here to tell you how to behave. It's, what are your goals? How can we help you achieve them? Now, obviously, we picked communities where we thought the goals made sense and that they had capacity, but it's their communities, and we're not trying to experiment with them. We're not trying to try out new theories or promote miracle cures. We may ask probing questions, but we believe it's really more about implementation than about strategy.
So one of the things is that I think we're collectively grappling with as we're thinking about this important area of collaboration is, that while there have been linkages between public health and healthcare for a long time in many ways, this genuine notion of a full collaboration to work on population health is relatively new. It's relatively new. And so one of the questions that arises is, what does success look like? What are we at this stage, at this particular stage, where we are now, not for a moment, not where we want to be, but at this stage, what should we think success looks like? What's realistic for us to expect as we develop these collaborations? And anybody who wants to answer that, I'll leave it up to you.
So at least for us, success is going to happen, I hope this is, success is going to happen 10 years from now, not now. But milestones are getting people to have clear programs with clear outcomes, with clear responsibilities. Who's responsible for this? Coalitions are great, but sometimes it means no one is actually responsible for the outcome. We've seen that quite a few times. So it's, first piece of success is just setting things up so that they will work. And then long run, we want to see high school graduation rates go up. We want to see fewer premature deaths, obesity reductions, and we want to see real estate agents telling us they're so busy because people want to live here.
Excuse me, I would say as a milestone or marker of success in the short term, I would point to two things. One would be leadership, and the other thing would be common vision. And when I say leadership, I mean competent leadership. That includes skills in how to talk to broad audiences and engage and bring in broad partners. But at the local level, we say at NACCHO oftentimes that all health is local, all public health is local, because it does have it's nuanced in terms of the priorities and things. But what I've learned as being a local health officer once upon a time, if you don't have the leadership commitment at the beginning, the county executive, the mayor, whatever, someone who's willing to see the need to braid funding, someone that's willing to see the need for collaboration for the outcome of improved population health, then you're fighting an uphill battle. On the contrary, if you do have that leadership, that committed leadership, you can expedite things very, very, very quickly. So leadership is important, and then from that comes a shared vision. So that's bringing those players into the sandbox, so to speak, and helping them understand where we're trying to go, that everybody's playing kind of a different position on the team, but we're all kind of pulling in the same direction because we want to see these outcomes at the end of the day. So those are two ingredients that I would measure as success and as a short term.
I would look at a short-term and a long-term goal. The short-term, which sounds easy, but I don't think it is we all have the same definition of population health. and we're speaking the same language. I know I've said that a lot, but specifically that. I think that's really hard to define, and the different groups that we're bringing together, different sectors, if we can really come together around that and then move forward, I think that would be a great start. So that's a first goal, or a really short-term goal. Long-term, I would like to see us, both to Esther and Lamar's point, that when there are people that want to get involved, that realize this is important, and want to join or know that they need to be involved, they know what to do. I find that right now, a lot of, on the primary care teams, they're saying, okay, this sounds pretty good, but what do I do? Or how do I do that? Or how do I add that into what I already do? We should make that so it's reasonably apparent, although it is definitely all local. But how can we support that and move that forward? So there's not this question out there of, okay, that sounds good, but now what? And I think a lot of that is still lingering. There's obviously a lot of different settings, a lot of different locations, but if we can have more tools, more of an idea how to move that forward, I think it would help all of us.
Do any of you have an example that maybe comes to mind as, given what you were describing as what success in the short term would be? Any example you'd say, here's a community that's done it well, or here's an example that I think has might offer a way to go about doing it?
I'll give you a
Yeah.
story.
Okay.
In Spartanburg.
Yeah.
The Spartanburg academic movement started out with a bunch of nice business leaders in the community saying, we don't have enough college graduates to work in our businesses. So they started exploring that issue, how can we help more students graduate? And they realized, oh, actually, we need to talk about college readiness in high school. And then they realized it's the middle school. So they're now doing early childhood education, and they're going to the source of the problem. I mean, there's also prenatal care. They're working with nurse-family partnership. Yet, just to make sure they're not a paragon of virtue, I asked them, what are you feeding the kids in the early childhood education? And they said, well, we do education, not nutrition. So but it's a very successful start. They've really gone back to where the problem starts rather than just trying to deal with the symptoms and make it easier to graduate.
Great.
I think that's a good point, especially coming together around a common goal when we're looking at how to move this in the community. One example I can think of is one of our members here in Maryland in the Annapolis area. They had a large and increasing amount of people that were utilizing the ER inappropriately likely, and on a frequent and repeated basis. And so the community came together. They had a grant, so there's the funding piece, but they decided what to do with that. First of all, they came together. They had physicians, they had a health system, they had the Department of Aging, they had the health department locally come together and take a look and describe what they think might be a remedy. They did some hot spotting. They mapped it out, and they found out that a majority, if not most, were coming from this one area, particularly one apartment building. And what they decided was that they were coming, they basically didn't have access to primary care, were not accessing local public health. They weren't accessing care at all. And so that group came together and decided to put in a continuity care primary clinic, a medical home, in the apartment building, and followed it along. But I think the key there is that they came together with a common goal. And they have improved their outcomes, both health outcomes for those patients or those citizens in that building and that area, and it's caught on. So, but meeting around a common goal can be a good way to get the conversation started and actually have a proven outcome and sustainable result.
I'd offer two examples. One that was, I thought, successful, and one that kind of got short-circuited along the way to success. So the success story I'll tell is has to do with is about Kansas City Health Department, a local health department, and they're tackling the issue of health equity. And it started with the leadership piece because the mayor recognized that was really very important to address those social determinants of health that we all talk about nowadays, to have the outcome of better health equity. And so not only did he support it from a leadership standpoint, but he also empowered them with the budget. Because if you show me your budget, I'll tell you what your priorities are. So your budget, but he also allowed them to engage with a community advocacy that does community development and community advocacy, actually to co-locate them with them so they could do some of those things and bringing in non-traditional community partners that have to be invested in changing and transforming the community. So hugely successful, and so they're able to tackle those non-traditional things that you wouldn't think health departments can tackle. So livable wage, housing security, food deserts, some of the other stuff that might be a little bit off the script for most of us. So that's a success, and it's ongoing. Then I can tell you about another community, Community X, we'll call it, where they were very successful in initially making the case to their health care delivery partners. So they came together around the community health assessment and some of the prioritizations and things like that. The data was a carrot to bring them there. Good currency. But then after that, once the plan was decided and everybody agreed on the priorities and things like that, they did not want to, healthcare delivery partners in this example, did not want to go and invest in doing some of those things. So instead, they decided to kind of cut it there and take the data and run, so to speak, and take the priorities and run, I guess. And so it really is about, when we're talking about bridging the gap, we're talking about a real substantive engagement, an exchange of resources to support what public health in this instance has to offer in terms of their programs and some of the things they do, home visiting, and some of the other things that can actually move the needle. So executing an implementation of the plan and supporting that monetarily versus just doing the front-end planning. So I would describe a continuum of success, one that got short-circuited after the planning period.
Well, we're going to continue this discussion and ask another question or two, but I want to bring you into the discussion, and so please think about coming to one of the two microphones that are on either side of the room, and if you do, feel free. You can certainly ask a question of anybody up here, but feel free to also share with us if you've had an experience where you think that there are, maybe a best practice, maybe a lesson from a collaboration you've been involved in. It would be good to hear that. So please come forward, and while you're doing that, I'll ask one final question. So I think what we said, and I think it's an accurate reflection of a lot of what we're doing now, is our focus is on establishing the framework, getting the framework right, deciding on getting the right people at the table, having the leadership of the quarterback in place, looking at the data, thinking about the priorities, beginning to get those pieces in place. And I agree, those are all critical. Let me ask you a question. If you were each going into your mayor's office, or the mayor's office in the community you were in, and the mayor basically said, well, it's great that you're doing that, but I come up for re-election in 4 years, and when I am up for re-election, I don't want to just tell people that I had a bunch of good meetings for 4 years where people were around a table and they were doing good planning. I need to show some results. What would you say to convince the mayor that there would be results? And there too, if there's an example where you can point to someplace where they were actually able to get results in 4 years in a different kind of a concrete way, what would you offer? Yeah.
So I would say, Mrs. Mayor, you have to be ready to spend some real money to do some real work. It's not enough to have your overburdened doctors hand out pamphlets and have nice meetings and a marketing campaign. The thing that we've seen that really works, and we've seen it in Muskegon in particular, which is my community, is a combination of, if you like, a curriculum and coaching. The diabetes prevention program, nurse-family partnership, all the things that are measured as effective include both some particular playbook, if you like, but also coaches, real people, training other people, being out in the community. There's nothing as motivational as another person, as opposed to an app or doing an online course or reading some material. So our communities, like so many around the U.S., are full of people who are unemployed. And some of them are not employable, but many of them could be valuable to society, get dignity for themselves, put food on the table, being employed as coaches to other people. And in some sense or other, that's what we're trying to do in a lot of the specific interventions. Whatever it is, apply more people that are trained and emotionally intelligent to actually bring that to a larger part of the community. And Mrs. Mayor, we guarantee you that if you do 4 years of this, you will get reelected.
Oh, very good.
So what I would do is I would go into that meeting understanding this, first of all, that reelection is the most important thing. And so that I'm not going to wow the mayor with my pie charts or my epi curves or my data. In that sense, I'm not going to wow them through their sense of altruism, of moral high ground. I'm going to have to get them in terms of constituent demands, because that translates into longevity. I'm going to have to find something that's going to be a very short window of turnaround, because they only got 4 years and they want to see some impact they can take credit for before it's time for reelection. So I would then basically say to Mrs. Mayor, I would say, first of all, I wouldn't come in by myself. I'd have some constituents there or some community representatives there to really help make this case and tell the personal story. And then if I had to speak with data, I would speak in terms of infographics and maps, so they could really understand where the hot spots are, and understand that there's some very low-hanging fruit that we can turn around in a year or two if we all get on the same page. So it really is about...
Maybe, well, what comes to mind as a low-hanging fruit? Hypothetical, so.
ER use, unnecessary ER use, asthma hospitalization,
Yep.
Preventable asthma hospitalization, diabetes compliance. I mean, these are all things that come, that can come with very quickly. So that would be my tact.
Thank you. Thanks very much. Julie?
And to that point, I think looking at what is truly impacting the constituents in that area, so that Mrs. Mayor is aware. And I think it's a good point to use those maps and use that type of information, but in a way that's meaningful to them and to their reelection. And how those people are going to be impacted positively, and to demonstrate how you're going to measure that and at what point. So that's pretty basic key milestones, but be very direct about that. I think it's important to take a coalition that's already been created. Perhaps that's not going to be the only thing that works, but so that the mayor sees that there's already people coming together around this and forming some tight bonds, and they're there to help the people and to help him help the people. So I think going in there with constituents, going in and talking ahead of time to some key areas and looking at a global plan, but to communicate that very well and in mayor speak.
Yet another language.
Yet another language.
Had to be trilingual.
That's right.
Great. Oh, good. I see some people there. Yes, please.
So good afternoon. My name is Diane Stalin, and I'm a consultant. I've worked with National Quality Forum, the state of Minnesota on their SIM grant, ASPPH, and others. One of the areas that I work in is population health work, and I find the references often to being bilingual, for example, of speaking healthcare and speaking public health, raises for me a question I've heard debated in a number of places, and that is, what is the relative role of organizations that are not healthcare, that are not public health, although your answer might be, well, they are part of public health, but that's my question for you, is corrections and education, transportation, and other entities which address the social determinants of health, what is their relative role to public health and healthcare? And a constituent group that is incredibly important is the individual. What is their role in this work? Because population health obviously is an aggregation of individuals. So what is the patient or the consumer's role in this?
Great question. Who'd like to tackle that
I can
one?
tackle that.
Lamar.
So I would say it's very important to understand that there is an ecosystem, and everybody in that ecosystem has a role. Multi-sectors, multi-sectoral approach is going to be very, very key in going forward. There will be a position for everyone to play, again, using the sports analogy. One of the things you need to start with doing is bringing them all together. And so NACHO, for instance, has assisted our members in doing trainings around, over 1,500 plus trainings or so around something we call MAP, Mobilizing Action and Partnerships for Planning, which brings together all those sectors. So the fire chief, the school teacher, the YMCA, et cetera, all the folks who are in the ecosystem who care about improving and elevating the health. So that's an opportunity for them to really understand the health report card, most importantly, to help chime in and give their key advice in terms of how we prioritize what we're going to go after. Is it going to be obesity? Is it going to be asthma? Is it going to be something else, air pollution? And then, to your point, identify their role in moving the ball down the field in terms of what they have to do specifically. So it is made up of individuals across different sectors, but everybody's going to have a position if they're brought into the process at the front end, which is so important.
But at the same time, you need to deal with reality. And in some places, one or the other sector is simply not going to be there at the beginning. And
Sure.
You need to make the other parts work so well together that the people trailing behind want to join because
Right.
they see it's working and they see that they could play a role.
That's right, early adapters versus
Yeah.
folks who are tagging along.
Maybe I would just ask, just as a follow-up to that, if we don't know what issue we're going to be dealing with, but if you were just at that very early stage of convening, aside from, and you could only invite, let's say, one other sector in the beginning, and you were thinking of, you've got public health, you've got the healthcare sector. What sector would you say, this one at least I'm going to make sure we put on the list to bring to that meeting with some preliminary work?
Schools.
You would say schools?
Yeah.
Uh-huh.
Mental health.
Mental health?
Sorry, I thought that was in health.
I didn't know. Is that in health? Is that in or out?
We wish it was
Whatever.
always included within, but sometimes you have to call it out or it gets excluded. So,
I think law enforcement would be important too.
law enforcement. So those are great. So thank you. Very good prompting of the question. Yeah.
Good afternoon. I'm Lisa Alexander. I work in the District of Columbia. I'm a PA. I've been a PA in primary care, practicing population health for 37 years, and I'm a faculty member in the School of Medicine and Health Sciences, where I'm the advisor to our student clinic. And we have been in business for over 10 years, but recently formed a collaboration with the Public Health Department in Prince George's County. And it was a novel approach to sort of helping our students understand gentrification, where they are coming to the District of Columbia. They thought the District of Columbia was always affluent and always had all these hip bars and restaurants to go to. And they were never here when these communities were forced out. And unfortunately, Prince George's County is one of those areas in the state of Maryland that had a lot of out-migration from the district. And we partnered with the Department of Health in Prince George's County, but one of the things that was a stumbling block wasn't so much getting the partners around the table, it was the risk aversion that a municipality had with utilizing volunteers to provide primary care. So first of all, the Public Health Department wasn't in the business of doing primary care. They were in the business of doing maternal and child health and HIV and infectious disease and surveillance and things like that, but the provision of primary care services was not something that they were in the business of doing. So we came into an awful lot of, a lot of hurdles around the practice, the scope of practice for our volunteers, and how we could, not only if we were asking for volunteers from George Washington University's physician practice or Kaiser, how could we protect those employees and their own institutions? So how could we get the legal status and the malpractice covered? So I'd say that these are some of the things that are going to always be a barrier. If municipalities want to extend their reach, then they might have to be more nimble and flexible, because those processes took much longer than we anticipated.
Very interesting. Thank you for sharing that. I think it's really important as part of this process that to highlight things that are either problematic or things that didn't go well when you tried them, because I think we're in this period of really learning about how to overcome hurdles, what to avoid. Julie, I saw you nodding as she was saying that. Do you have experience in that kind of experience?
Not directly in integration, but I did have a personal experience when I worked in a residency program, and we came together with an FQHC to try to provide maternity care together, both to improve access to care for the FQHC and also to provide more experience for our residents. And we hit a number of the same barriers, particularly around malpractice coverage, because there's a federal entity and then the private entity, and they wouldn't play together. But everybody wanted to do it. And we just said, it's not doable, and these were people that make things doable that were working on it. But that one was very frustrating. So it's a little different, but it's one of those kind of things that comes in where you have a good idea and you don't get quite past the barrier. You fizzle a little bit. Mm-hmm. So that's why I was nodding, because it sounded familiar.
Yeah, on the other hand, I have heard, and I'm thinking in particular of some of the southern states that I visited, where there wasn't always an FQHC in a community or the availability of primary care, where there were free clinics that had been developed that were largely staffed by volunteers. Mm-hmm. So I think in some instances, maybe it varies in terms of state laws, but I think
so.
In some instances,
exactly right.
there definitely are free clinics that are staffed by volunteers. So.
And that may be an area where we can work on. Yeah. It's hard to do it at a state-by-state level, but if there's something we can do, model legislation or other ways to help facilitate those, because I think there are definitely groups that want to come together and work on those.
Yeah, I mean, again, I think I would use this as a reminder of the potential value of the practical playbook, because I think if we identify issues that people are grappling with and then can identify where a community has overcome those or offers an example of a positive way of strategizing, that might be useful as you're encountering those.
I think it's a good idea.
So, yes.
Good afternoon. Earlier in the conversation, you were talking about long and short-term goals.
Yep.
And Dr. Wood, you mentioned your short-term goal would be a clear, agreeable definition for population health. Mm-hmm. So I'm wondering, could you share your definition of population health? And how does it differ, if at all, from public health? And anybody else on the panel?
Oh, man. I wish I had my script right in front of me. The vague answer to your question is we worked for a long time at my place of work, the American Academy of Family Physicians, to come up with one which I can't roll off the whole thing, but the core of it was that we were dealing with individual, what we would call population or panel health, and community health all enrolled together. It has a lot more fancy words in it, but that's the crux of it. What was the other part of your question?
Well, and how does that really differ from public health?
Public health. I think in the physician community, that is not widely accepted yet. So that's how it differs. It includes the public health definition and morphs them together so that they're functional and comprehensive and more focused on better outcomes. But if you look at the classic teachings, I think what we still say, and most of my colleagues, when we say population health, are not thinking population and community health. And I think those have to come together. It has to be that piece of the public health part put in there.
Sure.
And I'll be glad to share with you the full definition we came up with, which is beautiful after many, many months of work.
So, coming to this as an outsider, I didn't pay quite so much attention to those subtleties, but I hope my thinking's of interest. First of all, I see health as an asset that you should invest in rather than wait until it's too late and then you need to spend a lot of money on health care to try and recover that asset. This morning, hearing Bashara, why don't we subtract the costs of health care from the GDP instead of add them? Because this is money we shouldn't be spending, a lot of it, if we simply kept people healthy. So then I got onto this kick of talking about we want to produce health, and it just didn't sound right. And we realized finally what we want to do is cultivate health. It grows in people's bodies. It's something that makes them happier, more productive. It makes them resilient. Even if they do get sick with something specific, whether it's a virus or later on Alzheimer's, they're better able to deal with whatever physical or mental assaults they deal with. And you can cultivate it by nourishment, sunlight, getting people to exercise. But in the end, it's something that happens within people themselves and that they own and should be investing in. But most people just rent it.
Thank you, Mark.
And what I would say is that, and I've said this before, that population health, or I'm sorry, public health practitioners are population health experts. And the reason why I say that is because of the unit of analysis. They're not working individual at individual, one at a time. They're really working at the unit of analysis of the community, be it a zip code or a county or the like. So I'd say that for one. Number two, I would probably loosely adapt the WHO definition of health, which talks about physical, mental, and social well-being, not just the absence of disease, and extrapolate that to the entire community in terms of their opportunity for that level of individual health. And then thirdly, I would say that in my mind, I don't think this definitional issue will ever be resolved. Okay, I'm just going to throw my hands up. But I don't want us to be paralyzed because we can't be on the same uniform definition of what population health means. If we're dealing with an ecosystem of community, you want to draw a line around it, zip code, county, district, and we're talking about elevating the health of the folks that live in that community, giving them opportunities and addressing those determinants and those drivers of health, that's population health good enough for me, and let's get started. Thank you.
I think I would just build for a second as on that comment. I would say at CDC we were really struck that we were in multiple meetings where we were using the term population health, and everyone at the table had a different understanding of what it meant.
Right.
And personally I thought, well, the way to get around that is to, at first I thought, the way to get around that is to define a single and have a single definition and force people to adopt that. That was clearly a unwise approach, and so I'd say what we ended up doing is developing this notion of the 3 buckets of prevention as a way of saying everybody's definition is okay, and the work that we're doing isn't better if we have one definition or another definition, but there's a way of making sure that we recognize there are multiple approaches to population health and that they should be aligned whenever they can, and that there isn't one approach that should be neglected. We came up with 3, and they were, prevention within the clinical setting, traditional clinical setting. The other was prevention in a community setting, but patient-specific. So it had to do with bringing the care of the patient into the community with home visits and things like diabetes prevention program, et cetera, community health workers. And the third was population-wide, thinking of the entire community, not patient-specific. And just saying, we need all 3. You can call them what you want, but all 3 are necessary. And you, as an individual, a sector, you may focus a little more on one versus the other. That's okay, as long as we're all working on all 3 in a coordinated way where everybody recognizes the importance of the inclusion of multiple approaches. So.
Thank you.
Thank you. Yes.
I have a comment and a question.
Sure.
I'm Renee Kimon. I'm from UCSF, but the Fresno version, so in the middle of the San Joaquin Valley, which is really impoverished for those of you guys who don't know about it. I'm Associate Program Director for our PEDS residency program. And according to you guys, we're actually ahead of the game because we've already partnered with our schools, which unfortunately our high schools contain the mental health and the law enforcement. So we're hitting all 3 by partnering with the schools. We're on the Medical Advisory Committee because of our work. We're also just got invited to be on the newly formed Career Tech Advisory Committee because they want problem-based learning and associated with industry. So our problem-based learning is health. And we're doing it through our students. We're having our adolescents be teen mentors because you can't tell an adolescent anything. They have to figure it out on their own. And we're also having them going down to the elementary schools. We're pulling in Fresno State University, UCM Merced. They're also now going into the public school system. So that's my comment. That's how we're solving it. And that's where we're trying. And we partner with our Fresno County Department of Public Health And we're trying to partner up with also the Fresno County Department of Education, and we're in the process of trying to make a Fresno County Youth Health Corps, where it's high school centric. They worry about the health of their own local community. They bring it down to the elementary school model. We pull in the businesses in that local community. So that's what we're in the works doing right now. But my question for you is, I'm actually not a primary care provider. I'm a pediatric endocrinologist. So in my training, we didn't do any of this. And yet, if you think about it, you're really missing an important part of the healthcare team, because I see my diabetic patients way more often than I see their primary care providers. Okay, if I see my patients, I see some patients every month. I see some patients every 3 months. I guarantee you that's more than the primary care providers. So, and we also deal with those diseases that we're all trying to prevent. So my question for you guys is, where do you see our role at the table in this public health and primary care together? I think you're missing out on an important part of the healthcare team.
And I assume you're talking not just about endocrinologists, but
Well, no, it's a subspecialist,
but
sorry.
subspecialists. So,
Yep.
so non-primary care providers.
And
how
we're
do
not
they,
trained
how
in
do
this.
they? Yeah. So how do they fit in?
I think with us, the key piece is working on the, whatever you want to call it, I would call it the medical neighborhood piece, where we have better integration of care to start with between ourselves, between the primary care docs and the specialists. And I think that's going to look different for different patients and in different communities. Your patient that you see very often may not see me as often, but I may be seeing someone very often that you only see once a year. It depends on their acuity, what's going on with the patient. So I think the key there is that we're working together in whatever model that we want to call that, medical home, but where it's integrated with the subspecialty care as well as the other pieces in the community that we're talking about. And different places do that in different ways, but it's possible and it works. But it all comes down to communication, I think.
And I would add that nurses are a really important part of this. And often, so in Spartanburg, they have this great program called the Other 45. After you are in the doctor's office for 15 minutes and maybe get to talk to her for 7 of those, because she's also got to put stuff in her computer and whatever, then you go see a med student, and the med student, which could also be a nurse, spends 45 minutes asking if you have questions, telling you what the doctor just told you, finding out whether the doctor's advice is realistic given where you live and what kind of access to food you know, just like, this is a person who has your back, and it's not just the other 45, but it's the other parts of your body and your life from the specific one that might have brought you to the doctor's office.
I think that speaks well to team-based care within the clinical setting, and that could tie in very nicely with the subspecialty care as well.
Well, as peds, we actually have that team-based care, especially in the chronic disease model. And, you know, that's one of the things we have to worry about, but it seems like there's not enough. So those of us who do it, we do it. But it seems like in all of our training, there's a lot of us who have never even heard of this sort of stuff.
Well,
And so my question is kind of, how do you get it more into the training as well? Because I can talk to a lot of my subspecialists like, no, they just focus on the heart, or they just focus on the diabetes. They don't focus on all the rest of the issues that impact your patient's health. And yet, they should be, because otherwise we don't get compliance, you know, because they can't do it, and they haven't let their doctor know that. So my question is, how do we focus in on even incorporating this into the training more on a global level? Because I can definitely do it at my institution, but trying to do it across the states.
So I suspect we're not the experts in terms of that, but we would all agree it should be in the training. But I guess I would say to you, what attracted you? What would attract your colleagues in subspecialties? How would you, what's a good mechanism for reaching out to, say, the subspecialists in this community we were hypothetically creating, and letting them know a meeting was coming up they might be interested in?
I think it would help by going to the boards of the individual places, you know, as in terms of dissemination. I think you're going to get different people involved for different reasons. I'm an educator, I always have. I tell my patients my job is to be their health coach, and I'm going to be a pain in their butt, which I am. But I really think it depends on really getting the word out. And if you're not getting the buy-in from the key people in the area and they're not bringing this down, I mean, obviously any of our residents who goes through our training program and wants to be a subspecialist, they're getting trained in this. But I don't see this happening across the states as a whole. And I really think it's going to take the buy-in of people in the various, like mine would be Pediatric Endocrine Society or the Endocrine Society as a whole, getting into those communities, making waves. Like, the only reason I knew about this was I'm on the Community of Pediatrics Training Initiative through the American Academy of Pediatrics, and they sent it out to us, which is how I ended up here. But I think that that's not going to be true for a large part of your subspecialties. I know Peds GI actually has an advocacy so it would be good to go through them. But I'm thinking as we get on as you guys are building these things, get us on your lists as well.
That's great. Thank you. Great comments. Yes, next.
Hi, I'm Sarah Page from HAP Housing in Springfield, Mass. We're a build site. And as you've been talking about the need to be multilingual, I haven't heard at all as much mention of the community development field and community development organizations as I would have thought. Most of the build sites, it seems, include a community development organization like mine. And we typically are bringing together public safety, youth programming, housing, economic development, lots of the topics that really are affecting the social determinants of health. So we often are bringing many of those together. So partnering with us across the country makes lots of sense. And you know, I know that some of our national intermediaries like LISC, the Local Initiative Support Corporation, NeighborWorks America, Enterprise. Bishara was mentioning the Community Development Financial Institution movement that's really strong. There are lots of partners that all need to be at the table, but you can bring many of those partners when you include community development corporations. So I was curious if you all on the panel are working with your community development organizations in your communities.
Great question, and I've gotten the 1 minute notice that that's all we have left, so quick answers to that. Does that?
It definitely resonates. It's definitely very, very important. We have worked, I've worked with those development partners at the state level. We encourage our members to do it at the local level. The example I cited in Kansas City is very much on board with that, and that's how they've gotten a lot of traction, is really bringing the community development partners together and really kind of an asset-based community development model in terms of addressing what they have already and then building from there. Even in the most impoverished or underserved communities, there's some assets that can be built on. So that's definitely going to be a key in going forward.
So seek out your community development
And
agency.
come
yes.
talk to me.
And Esther has experience in working with those, have you?
No, come talk to me so that we can.
You can link up to those.
We're working with FEMA in Lake County, which had wildfires, but would love to talk to you about doing more of that. Thank you.
That's great. So maybe I'll just, it looks like I should be saying thank you. I was going to say closing remarks, but instead I would say thank you for this conversation. Thank you for joining in with the conversation with us. And please join me in thanking our three panelists.